Good morning, everybody. Welcome and thank you for joining us for this seminar, Revisiting Concepts of Evidence in Implementation Science. This event is part of the 2023 Institute for Implementation Science Seminar Series, which features lectures with leading experts in implementation science. Registration for our upcoming seminars and recordings and slides from past seminars can be found on our website, which we'll link in the chat. A few quick announcements before we get started. This seminar is being recorded and the recording will be posted on our website after the event. All of your microphones are muted, but if you have any questions, please post them in the Q&A box as we will have time for questions and discussion after the presentation. CHESS continuing education credits are available for attending today, and details on how to receive credits will be emailed after the event. I'll now turn it over to our Institute co-director, Dr. Bala, to introduce our speaker. Thank you.
Thanks, Ricky. It's really my pleasure to introduce Dr. Brownson, but before I do that, I also wanted to invite Dr. Fernandez to say a couple of words.
Just wanted to offer my welcome to everyone and thank you for joining us. We've had some awesome speakers so far in this seminar series, so if you've missed it, we encourage you to take a look at the recorded sessions. And I will turn it over back to you, Dr. Bala, to introduce our speaker today.
Great. Thank you for agreeing to present here, and we're really looking forward to your presentation, Dr. Brownson. Dr. Brownson is the Lipstein Distinguished Professor of Public Health at Washington University in St. Louis. He studies the translation of evidence to public health practice and policy with a content focus on environmental and policy determinants of chronic diseases. He directs the Prevention Research Center, a center that develops innovative approaches to chronic disease prevention through translational research, and co-directs the Washington University Implementation Science Center for Cancer Control. Dr. Brownson is the author of over 600 peer-reviewed articles and 15 books, including Dissemination and Implementation Research in Health, Translating Science to Practice is really the book for D&I research in the field. He has received numerous awards for his work. Among these, he's the recipient of the American Public Health Association's Abraham Lilienfeld Award for Excellence in Teaching and Mentoring, and the APHA Award for Excellence. Dr. Brownson is past president of the National Association of Chronic Disease Directors and the American College of Epidemiology. We're so thrilled to hear about revisiting concepts of evidence in implementation science. I will hand it over to you, Dr. Brownson.
Great, thank you. Thanks for the kind introduction and really great to be here. I sort of wish we were all together in the same room, but this will suffice. We learned to do some things differently the last several years. So glad to be with you today. The reason we worked on an article that comes into this today, and a lot of this is sort of framed around that article, and it got us thinking about this foundation of implementation science really is evidence. But then when you start digging into evidence about what it means and what it means for different audiences, how we generate it, how we use it, who generates it, who receives the evidence, how they receive it, it's not a simple thing. And so if anything, I'm hoping today through this set of objectives that it will probably raise as many questions as it answers, but hopefully get you thinking about some things. And we'll have time for some question and answer at the end. So you can either go ahead and put them in chat as we go, or you can save them for the end and we'll talk about it. So in this next 40 minutes or so, we're going to talk a little bit about some of the founding definitions, some of the types of evidence, a little bit how we gather evidence, how we sort of traditionally gather evidence, and maybe a bit of new thinking. There'll be some core concepts. We'll cover things like context and external validity and health equity, things I know that many of you here work on a daily basis. We'll talk a little bit about thresholds for what that's worth, at least my view of this, and then a little bit about tools and resources. The cartoon sort of says it all to me, and I think this is why we enter our careers, not just to do research for the sake of research, but that we need to do something with all the research we do. You know, we spend something like $40 billion a year on health-related, the federal government only, not the private sector, on health-related research. And if you look at how much of that research is truly changing the daily lives of patients and populations and reducing inequities, it's not enough, and we need to do better. And that's the foundation for implementation science. So quickly, a couple of background topics. This one kind of makes your head hurt a little, but what it looks at is, many of you know the idea of ecologic frameworks. This is what, a 7-level ecologic framework, I think, and this is around cancer care. This is an article Steve Taplin did now about 10 years ago. All it shows is the fundamental importance of these levels of effect, in this case, on cancer-related outcomes. You could put any health condition, any risk factor you want to look at, and there are these multi-layered complexities that determine whether someone, in this case, has adequate cancer care and has improved cancer outcomes. And those go all the way to the individual, to the national. You could actually put global on here too. I know many of you work on global health issues. So just to think about, it's a really complex, multi-level world, and we need to make our research more multi-level as well. My long ago training is in epidemiology, so you all know this is not Jon Snow from Game of Thrones, a different Jon Snow. This is the Jon Snow in London, and cholera is still around, but it was a real important disease, and killed a lot of people from water contamination. Back in the mid-1800s, 53,000 people killed, and this is the famous thing that went against the prevailing theory of the time, what was called the miasma theory, that disease and cholera were basically caused by bad air. Turns out it was by bad water. The Broad Street pump was removed. Did a spot map. Jon Snow did a spot map. The point of this one is, and this is, the number of deaths went down to 0. You can't even calculate a relative risk when you've got a 0 cell. You can, but you have to do some different methods. But the important part is, a lot of these huge relative risks are gone. And so we're left with more subtle risk, things that where the differences in level of risk make it important that there are many other confounders that might explain what's going on. A parallel more in the modern world could be smoking and lung cancer. We know if someone's a lifetime smoker, they might have a 20-fold risk of getting lung cancer. Most of the things we work on these days don't have 20-fold relative risk, or don't have the sort of excess risk that we saw here around the famous Jon Snow example. The idea of evidence synthesis has been around, probably in the US. I think I would date it back to the time of Abraham Lincoln, who formed the National Academy of Sciences. You may or may not know that one of the themes of the National Academy of Sciences was to synthesize evidence. So that's been around, for well more than 150 years. The idea of meta-analysis was introduced in the educational sector in the mid-1970s. And then this growth of evidence-based medicine, especially from Archie Cochrane, who published a famous book in 1972, basically saying that a lot of what we do in medicine isn't evidence-based. The growth in evidence-based public health in the late 90s, and then the synthesis movements, in a way, like the Cochrane collaboration, the Campbell collaboration more in the social sciences, and then the United States, the clinical guide and the community guide came along a little bit later. So this idea has been around a long time. One of the founding books in our field that many of you know about is the Diffusion of Innovation, that was first published by Ed Rogers back in the early 1960s. I've seen it said that it's the second most cited book ever. And a lot of the themes are still around today. Won't spend a lot of time on this, but if you look down the left side here, you see things about the innovation in implementation science. That would be the evidence-based practice or policy. What's the advantage? Is it compatible with people's organizational or individual behaviors? Is it too complex? Can we try it out on a small basis? Can we observe benefits from it? And then the type of decision that's being made, the communication channel that's being optimized, the nature of the system itself. And in implementation science, that's often the organization where we're trying to affect change. And then the change agents are often really important. A change agent might be an opinion leader within the organization where you're trying to do implementation science. So even though this book has been around a really long time, it really is many of the founding principles. And if you haven't read or seen the book, it's worth picking up. And this was the cover of the 5th edition. All right, a little bit more on core concepts. One of my favorite quotes is "Don't let the best be the enemy of the good." That came from Voltaire. And then the caption of this one said, then we've agreed that all the evidence isn't in, and even all the evidence we're in, it still wouldn't be definitive. The truth is, if you put the bar too high, the evidence is never going to be definitive. So it's deciding where that bar would go. We'll talk a little bit later about some of the ideas of thresholds. The evidence for implementation science comes in different flavors. In epidemiology, it might be etiologic evidence about whether risk factor A causes disease B. It might be intervention effectiveness, and then it is implementation, of what many of you focus on in your work. I think too often we focus on the evidence-based practice itself, the evidence-based intervention. We haven't focused enough on context, those circumstances, the conditions that surround implementation. Going back to that ecologic framework, these are multi-level, they're dynamic, meaning they change over time, they're constantly changing. They're closely related to external validity. We'll get into some of the issues related to external validity in just a few minutes. There are many gaps in evidence, especially around equity and equity relevant evidence. That can be something as simple as, where was the evidence developed in the first place, or has it been adapted properly with input from the community most affected by inequities? And then we need a robust definition, and we need to think broadly about evidence. When we think of evidence, and some people think of evidence as just research evidence. And so this is a schematic of a variety of different types or even sources of evidence. If you go toward the top, those are the things that we would call more of the scientific evidence, the things that end up in the scientific literature, that end up in a systematic review. If you work your way down, you might have high quality evaluation data. You have qualitative data. It's a very important form of evidence. And often some of the best implementation science projects triangulate data. You use quantitative data and qualitative data. And then you go down below and you get to things like word of mouth and personal experience. And I think in general, we would say those toward the top are more objective and those toward the bottom are more subjective. But you've probably heard the saying that, beauty or art is in the eye of the beholder. Evidence is too. So if you work in the policy setting and you're going off to the Texas legislature to testify about some new program that you're trying to get funded or a bill you want passed, how a typical legislator thinks about evidence is going to be very different than how your typical researcher thinks about evidence. And so and I teach a whole course on the translation of evidence in the policy. Part of what we have to do is if we're trying to make change, think about how the beholder is looking at evidence, not necessarily how we would look at evidence. So that's important to keep in mind. There are a lot of typologies out there. I actually like the term typology better than hierarchy, because hierarchy implies that one type of evidence is better than another. The best approach, and we'll talk about this in just a minute, is fitting the evidence to the kind of questions you're trying to answer. There's a nice article that Mark Pettigrew wrote about 20 years ago, and it's cited at the bottom here: evidence hierarchies and typologies, horses for courses. There's a saying that the Brits use, that the horse for the course. So some horses run really well on wet tracks and some horses run really well on dry tracks. And we need to think of evidence a little bit more like that the evidence fits the kinds of situation, the kind of questions we're trying to answer. Their hierarchies are useful, but they're not a solution, especially to policy and community. So if you're thinking of the randomized trial is always going to be at the top of the evidence pyramid, there are a lot of policy questions you can't really answer with a randomized trial. There's another nice article published by Hassan et al. That looked at this typology and looking at both interventions and implementation and some of the outcomes that come for those. So they outline the interventions, sort of what are some of the core components there you should consider. What does high quality implementation look like? The third bullet is more about external validity, and we'll talk more about that in a minute. And then the outcomes that are not just the sort of biological outcomes, but outcomes related to the preferences of the end users, of the audiences we're trying to work with and affect. This one's a little busy. One of the parts of my usual daily work is teaching a course in evidence-based public health for practitioners. And we use this outline because we want people to think about, we talk about 3 different kinds of evidence. Type 1 evidence is what we would call etiologic or evidence of burden. So that would be something like smoking causes lung cancer. We have a lot of that evidence. In some areas, I think we almost have too much of that evidence, too much etiology, and not enough intervention and implementation. What does that tell you? Well, it tells you something ought to be done about smoking. It gives you no specificity on what to do or how to do it. Type 2 evidence is relative effectiveness of some type of an intervention or policy. So if we use the smoking example, it might be a price increase with a targeted media campaign will reduce smoking rates. And we know that that's true. That's an effective policy intervention. We have a moderate amount. We have less, certainly less than type 1, but we have enough on most important health conditions to take action. This gives us more specificity. And then third type is really what I think most of you are interested in, is implementation evidence about adaptation, translation from one setting to another. If we carry the tobacco example, a lot of the early work in high-level tobacco control was done in California and Massachusetts. If I'm working in rural Mississippi and I'm trying to affect tobacco the rates of tobacco use, I'm probably not going to be able to directly use what California did in rural Mississippi. So this idea of adapting, changing to the context, implementing it in the variety of different settings and populations. And we have even less of that kind of evidence, and that's what makes the field of implementation science so needed and so exciting. We like to also, this is a very simplified version of a broader framework that we have. But when you think about building the evidence, what you really need to start with is start with some framework. So that can be an actual behavioral science framework, or it can be one of over 100 different implementation science frameworks. Think about the questions you're asking, the kind of evidence you would need to answer those questions, and then you begin thinking about the design, the evaluation options, and the measurement issues that come into play. And we have in one article that Steph Masuka led a few years ago, we have a more fleshed out version of this thinking as well around implementation science. And I mentioned before the sort of triangulation of evidence. Usually in implementation science, the multi-method or mixed method studies can be the most informative and the most useful. So that's important also to think about. Another part, and I sort of alluded to this, is this idea of randomized trials. And I think in many areas, and I'll start with the quote in the upper right there, if we want more evidence-based practice, we need more practice-based evidence that our great colleague, Larry Green, brought forth in an article in American Journal of Public Health now about 15 years or so ago. Traditional RCTs are often considered the gold standard for assessing causality, especially looking at internal validity. As you know, the number one thing they do is to decrease the chance of selection bias. Often the studies are done under pretty tightly controlled conditions. We aren't always designing for a variety of different conditions for implementation, sustainment, the variability, the sort of dynamic nature of evidence. And they're often not pragmatic. They're often not working in a way that is the practical way that someone in one of the settings would take it on. And the policy evaluation can present some unique challenges as well. It makes it difficult at times to translate the findings into the real world. And there's often a voltage drop when we do something under highly controlled conditions. The more we move into real world conditions, the trickier it can get. And some of that voltage drop is not taking into account external validity, the variations by setting and population. And so here's a fun little bit we call the 3 little paradoxes. Take off from the three little piggies. And so here are, I guess we would call these sort of paradoxes or tensions. One is the internal validity, external validity paradox. The more rigorously controlled the study is, in other words, the higher the internal validity, the less reality-based it may become because of the impact on scalability, generalizability, the idea of this voltage drop. There's the specificity generalizability paradox, the second one. The more relevant, particular to the local context, in other words, the more specific it gets, the less generalizable it may become to other contexts. If you're working in, we have counties in neighboring counties and rural areas in Missouri that have drastically different rates of cardiovascular disease or cancer. So there's a localized effect that we have to take into account that might limit external validity. And then the other one is homophily and distancing. And homophily is, I think it's derived out of sociology. And that's the idea that people living and working together bond with each other. That's sort of the idea of the birds of a feather flock together. If you think about embedded researchers, the idea of participatory research, the more you interact, which is an effective way of doing research, that might also influence the real world utility of findings. So those are things to keep in mind. There's always going to be some tension here, but in general, external validity wants to put more emphasis on a lot of the issues that we often overlook in many of our study designs. I'm a baseball fan. Baseball season is over. I suspect there are a few happy baseball fans in Texas this year. So hats off. There's a famous, my favorite baseball movie, The Field of Dreams. And the famous quote in there, as you probably know, is if you build it, they will come, or if you build it, he will come. We've often thought that way about evidence, that if you build it, if you have this evidence-based practice, you put it out there and clinics will do it, or practitioners will do it, or public health agencies will put it into their daily practices. And in the diffusion theory and what I showed earlier, I didn't talk about the notion of early adopters. That holds really true for early adopters. It doesn't hold nearly as much for later adopters. And part of why it doesn't work so well at times is this idea of that we're not, and the D4D I have on this slide is designing for dissemination. Part of it is we don't match the way we disseminate evidence with the impacts or how the end users, usually practitioners or policymakers, take it up. This is a paper that we did a few years ago with about 200 public health and clinical researchers in the United States and Canada. And we simply asked them, I'm going to highlight two things here. I'll go ahead and click through. I'm going to highlight two lines here. What's the method of dissemination that most impacts your career? And then what has the most impact on practice and policy? A little bit different there, 94% compared to 16%. We've had other surveys where the typically used and impact can be 100%. And then the other one is face-to-face meetings with stakeholders, 0 impact on career, but 40% impact on practice and policy. So there's all kinds of issues that come into play here. Several of them are that how do we line up how researchers put their research out there compared with what practitioners want to see and how they receive it. We have a new project we just finished that takes a lot of these designing for dissemination concepts, but we looked at them from the practitioner point of view, not the researcher point of view, and we're trying to get at things like what types of evidence do practitioners trust the most? How do they get information? How would they like to get more information? And so that is also an important part of it, is to try to look at both ends of the evidence pathway. All right, so a little bit then about equity in implementation science. A lot of you know this, but we've had over the last 120 years or so a remarkable gain in life expectancy, about a 30-year gain in life expectancy. If you frame it a different way in this idea of social math, for every 1 hour of time that elapsed, on average, we've gained 15 minutes of life. Probably in human history, no larger gain in average life expectancy in 100 plus years than we've ever seen. But what do we know about that? Well, we know the last few years, the life expectancy has gone down, mostly because of COVID, but other sometimes people call them disease of despair, and that is homicide, suicide, and opioid and drug addiction in youth, because those tend to affect people at an earlier age, which has a bigger overall impact on life expectancy. And then I think it's also sometimes what looks a little invisible with this look is this look. So these are data from 2019. So basically from 2019 to 2021, looking at average life expectancy by racial ethnic group across those years. You see a drop for all of the groups here, but you see really dramatic drops really for three populations: the American Indian Alaska Native population on the far right. You see the current life expectancy among American Indian Alaska Natives is only 65 years of age. That's the same as the overall US life expectancy back in 1944, 80 years ago. And so other groups, Hispanics have dropped 5%, Blacks have dropped 5%, and the American Indian Alaska Native have dropped 9% in just a few years. So while there's progress, there's also an imperative to do things differently. And that's really the founding part of the idea of equity. And we did this article a few years ago to there's been a lot of others, and ours isn't the best by any means, it's just one of them, but to try to get people thinking a little bit differently about how implementation science could and should relate to health equity. It boils down to justice, justice in what we do. The diagram on the right, you've seen some version of that in the part. Equity is often defined as the state quality or ideal of being just, impartial, and fair. Equality, if you look at the top, everybody's got the same bicycle. So that's equality. Well, that's not fitting the needs for people. It doesn't take both current and historical disadvantage of different populations. Equity in this simple diagram is everybody is getting the device that's going to move them in the way that they can move. And so what the big difference between equality and equity is that it's not taking into account historical and systemic injustices that have accumulated over time. And we could talk more about that. In our article, we outline 3 overarching large challenges, the limitations of the evidence base that I've talked about quite a bit already. And part of that is not taking enough of an upstream approach, the underdeveloped methods and measures. And the example I could use there, Peg Allen in our group led a review of policy implementation science measures a few years ago, identified 170 different measures out there for policy implementation. There wasn't a single one of the 170 that had an explicit focus on equity. And so there's a big gap around how we measure things, in this case around policy, and then not providing enough attention to context. Context also intercepts with the example on measurement. A good example of that, the way we typically measure sort of socioeconomic level in our studies is household income. If you look at the difference between white households in the US and Black households in the US, on average household income, I think the white household is about 1.8 times higher than the typical Black household. But if you look at household wealth, that is accumulated wealth over time, the difference between white and Black families is tenfold. And we very seldom try to measure wealth in any of our studies, which takes in context and the historical disadvantage. And so there's some new thinking we need around issues like that. I won't spend a lot of time, but basically the way we put this paper together is we took one of the overall challenges and then we built a series of recommendations, and we end up with 10 recommendations. We talk about what we mean, a little bit more granular detail of that recommendation. So the first one here about social determinants, what we mean with that, and then who might be primarily responsible for that, who are the actors. And we did the same thing around, so this is for the first 2 areas, and then we did 8 other areas around the measures, the context, and then we had a couple that didn't fit really cleanly, like building capacity, that's training and who trains and how they're trained, and then how you disseminate findings with a stronger focus on equity. And to kind of bottom line it, which is not rocket science to any of you, I think, health equity really does begin with justice. we argue in this piece on implementation science that every project where you've got data under your control, I would put that little caveat in there, because if you're analyzing secondary data, you can't go recreate the data that's already there. But any project where you're collecting data or have some say over the data ought to include equity in one of two ways at least. One, it's the main goal and central feature. That means from the start, how you design it, who designs it, the questions, the model, the activities, all those focus on equity. Another way was, this is sort of the do no harm, or we use the term leave no one behind, that at a minimum, we're keeping in mind the implementation of the project, we're monitoring equity or disparities, and we're making sure that they're not being widened. Because there are examples in the literature of a practice or policy we would call evidence-based, when implemented as designed, make equity worse. They increase the disparities, and we should keep an eye on that and make sure that that is not happening. So that's a bit about the backdrop with equity, and then I'm going to talk about sort of the audience. So we talked about the what, sort of what is evidence, but what about the who or the whom? And so thinking about that. Well, who are your audiences? If you think about the work you do, and when you're trying to study something or disseminate evidence or make a change in a practice or policy setting, our audience can be pretty broad. And I took researchers out of the mix here. I'm going to take that as most of you, I think, on the line are researchers, and so assuming you know how to communicate and disseminate evidence to other researchers. But if you think about practitioners, that can be a public health practitioner, someone working, for example, in governmental public health in a local health department in Texas. Or it could be a clinical practitioner, someone working in an FQHC or another clinical setting in Texas. Another could be a policymaker at all different levels, from federal to state to local. And there's crossover. So if someone is the head of an agency, they might not be elected by anyone, but if they're making decisions about resource allocation, they are making a policy decision on some level. And so as we think about these audiences, some of the things to keep in mind are around communication, dissemination, framing. Are we taking a gain mindset or a loss mindset? Are we talking about dollar saves or lives lost? Are we talking about assets that a community has versus deficits that a community has? Most of the communities that I've worked with over the years are kind of tired to hear about the deficit mindset. They want to hear about assets and how they can build on those assets to make life and people where people live, work, and play, make it better for people. How are messages perceived? People want messages to be as unbiased as possible, credible, and then how do we deliver them? I won't have a lot of time to go into this, but delivering them in a journal article for many of the audiences in the practice and policy audience is probably not the answer, as you know. When we do a deeper dive on this, and in this article you'll have in the readings list at the end, and we'll have the slides for you if you want them. There's a simple communication model developed, believe it or not, back in 1949 around communication. And the idea here is to take apart any communication or dissemination effort and break it into the source, the message, the audience, and the channel. So where's the evidence coming from? How are you packaging the evidence in the message? How's the audience going to receive it? What do they look for? And then channel is how it's delivered. Channel is sort of a health communication term. And a place we start when we do this in the audience is to think about, this is a little planning matrix that we use. And in here we've got 3 core audiences: the public health practitioners, the clinical practitioners, and the policymakers. They all have different characteristics. They have different ways of thinking about evidence, the messages that gets to them. So if you compare a clinical practitioner, the message might be, it's going to improve patient care, it's going to improve equity. For a policymaker, that third row down, it might be, it's going to serve my constituents, it's going to give a return on investment, or it might get me reelected if I'm an elected official. So how you reach those through the channels are going to be very different. And so sort of the policy, the dissemination message here for a policymaker is going to look different than for a practitioner. You can also add sort of the general public in there. And even the general public has different audience segments within it. And so we can learn a lot from this issue of audience segmentation that comes out of the communication world. And then the notion of evidence thresholds. And this is my version of evidence threshold. So take that for what it's worth. It's probably parallel to burden of proof in law. In public health, urgency matters. So if we're in the middle of a public health crisis, the threshold for how deep the evidence is, how many randomized trials we have, how much we test something is probably different than if something that's less severe, that's not as urgent. And urgent can mean different things to different people. So clinical practitioners, I would argue, have the highest bar for evidence. They have high financial stakes. They have regulatory agencies for drugs and medical devices, agencies like the FDA. Public health practitioners, let's say state and local public health, is probably variable. It depends on their training, their setting, their leadership, the resources they have, even the funder. For example, the CDC and a lot of the grants they put out to public health practice will require the use of evidence-based interventions. That's what EBI stand for. But we found, and I know others in this group have done this work, it's tough to track implementation. It's tough to track whether what someone writes in a grant they're doing is actually aligned with what they're doing in the real world. And then policymakers are less likely to be based in science. There are evidence-based policy examples out there, but it's often more of a mix of policy, politics, timing, luck, persistence, a whole bunch of things that come into play. And I did one little bit on policy evaluation as well. Policy change, as you know, has probably the greatest opportunity to change lives and reduce inequities. But it is subjected to what we call the inverse evidence law. The way we traditionally value evidence at the highest level is the hardest way to study something that is going to have the biggest impact. So we somehow have to think about evaluation a little bit differently than we would for the gold standard sort of randomized designs. The upper right hand of this is the cartoon. This famous quote: you never want to see two things being made, legislation and sausage, that they're messy. You don't ever know what goes into them, and that affects evaluation as well. The biggest difference for policy is that you don't have control over the implementation of the policy itself. It makes evaluation very challenging, and the timeframes are often shorter for policymakers and longer for researchers, probably kind of in the middle for a lot of practitioners. So that's important to keep in mind. And then it's also to keep in mind, I think, sort of where we're coming from and this nexus or lack thereof between the policy world. So let me click on this and see if it's gonna work for you. We're gonna have a little trip out into Texas today. We've got a problem. Person in the balloon says, "Where am I?" And the person down below says, "You're 30 yards above the ground in the balloon." And the person in the balloon says, "You must be a WashU researcher." I could put in there, "You must be a University of Texas researcher." I am. How did you know? Because what you told me is absolutely correct. Whoops. Absolutely correct, but completely useless. In other words, good information, not real operational, not very actionable. You must be a Texas legislator. You must be a policymaker. I am a policymaker. How did you know? Because you don't know where you are, you don't know where you're going, and now you're blaming me. So, it's kind of a funny little thing, but there's also some seriousness to that we have gaps and we're not connecting between these audiences the way we should be. And that's on us. It's on the partners we work with, is trying to do things a little bit differently than we have in the past. All right, so I'm going to wind up with this part and then a little bit on tools and resources, and then we'll go into questions. There are a lot of gaps in our knowledge about evidence, so I just sort of came up with 4 here. There's probably 5 pages of gaps we could talk about, and you could identify gaps that you see from the research world. We could also see gaps that practitioners and policy makers have that might look a little differently. One is we probably need to study null or ineffective interventions more, about why they didn't work the way we thought they would work. What is the strategy from it? What does it mean to be evidence-based? And was it the right intervention in the first place for a population we're trying to work with? Are we doing underpowered studies? There have been a lot of underpowered studies the last few years in COVID, and is there publication bias showing up where we're seeing more of the publication of positive results than we are of null results? The next two are sort of layered together, de-implementation and misimplementation. De-implementation, if we have low value or ineffective care, we should stop doing it. There's estimates in the US healthcare system that up to a third of what we do in healthcare should be de-implemented in one form or another, or changed in a significant way. Misimplementation is a term we coined in public health, and it has two parts to it. One is I stopped doing something that was effective. Okay, that's one form of misimplementation. Another is I'm continuing doing things that are ineffective. And both are important. The discontinuation of effective programs for public health is often a funding issue. The other end, though, the continuing ineffective programs is often a more complex set of issues, of contextual issues, leadership, how evidence is transmitted, and there are more actionable items in that one. And then the third part is requiring more complex systems methods. Essentially, every issue you're running into is some sort of a systems issue, either a systems breakdown or parts of the systems aren't working together in the way they should be. All right, I'm going to wind up quickly, leave you with some resources, and you'll have these slides if you want them. In our paper, so this is the paper that frames some of the remarks today, we found a set of domains. We sort of put together some tools within what is here 4 different broad domains. And then with each of the domains, I just showed an example for that first domain, the engagement and partnerships around some online, and these are all free tools that are available. So if you want to do a deeper dive, there's some resources for you. And then there's some more, I guess I would call these more sort of meta resources. One is What Works for Health, which I think is a tremendous resource, both for data with the county health rankings data, and What Works for Health, which is sort of a version of the community guide that brings in systematic reviews, but it also brings in more expert opinion and a broader range of evidence than some of the systematic reviews do. So that's a great source. There's another one in maternal child health that has a lot of really great resources and tools. And so even if you're not working in the MCH area, there's some really valuable tools here. And then one for rural work, the Rural Health Information Hub, which is a great source, both a mixture of data and some stories that are built in here as well. All right, take-home messages. This is tough stuff. It's complex, it's multi-level, it's contextual. Often the structural and root causes are under-addressed. All of us, funders included, reviewers, need to think about and adopt a more robust definition of evidence and making evidence fit more of the questions we're answering, the context we're in. And then there are a lot of tools and resources that can help you out on your journey. So keep that in mind as well. We've got articles. So a lot of the articles that I referred to here are listed there as well. And then I've got some thank yous. I always think like I've probably had 2 original thoughts in my lifetime and everything else I've stolen from somewhere else. And so probably these are some of the people who thought of this stuff in the first place as we talked. All right. So I think I should come off of share. So that's it for the formal part. So I'm ready for questions.
Yeah, thank you so much for really an insightful and chock full of resources presentation. And in fact, a lot of people asked if the slides would be shared and the recording would be shared, which it will be. So it's going to be really useful. There are several questions here that I'll jump in right off so we can get to as many as we can. So the first question is about one of your earlier slides on homophily. And sort of a comment slash question, which is, well, maybe the interaction is and should be part of the intervention itself, and with a question mark. Do you have some thoughts to share about that?
I do. So that was Elizabeth, right?
Yes.
Yeah, Elizabeth, that's a great comment. In fact, maybe what it is, it's part of the intervention, and we do a better job of tracking that as part of the data collection within an intervention. You know, there are there are some of these, you probably know about some of these adaptive designs, smart designs in implementation science now, where you're actually adapting and changing the intervention that could be based on the interaction as the intervention or the implementation strategy is being put together. So I think that's a really great point, and it's probably an extension of, like, so every one of those paradoxes, there's sort of a different counter to it. So maybe this isn't a paradox, maybe this is just something we need to take into account and report on better and keep better track of. So I think that's an excellent
Yeah,
comment.
that makes sense. The mismatch in design for dissemination is really informative. And this question really is about, do you see any institutional changes in the trend of not appreciating community engaged work in terms of academic promotion? If not, what individual researchers, especially early career investigators should navigate doing to get a good community/impactful work and pursuing academic success? Great question.
Yeah, that's a great question. You know, there are places that I won't try to name off specific places, but a few come to mind, and this person can also write to me separately if you'd like. There are places that I think appreciate sort of participatory research in a different, better way than others. It can be manifest. So even I'll give you one local example, because I can pick on our own medical school. Our medical school now has adapted they're in the process of adapting and adopting a new set of promotion tenure guidelines that takes a much broader view of what impact should be for an academic career. And so there's a model here developed by Doug Luke and crew called the TSBM, the Translational Science Benefits Model. So if you think about those sorts of benefits, so I think layer one is, what do we call impact in the first place? The things we typically have called impact in the academic world are the widgets that are easier to count, like publications and grants and books, and they're easy to count. They're easy to count. They're not always easy to get, but they're definitely easy to count. Impact in the real world is different. So I think that's part one of your question. I think part two is, if someone's doing true engaged work, participatory work, it's almost always going to take longer. And so I think the other part is when, and I don't know the career stage of the person asking the question, but I think my follow-up question would be, at your career stage, if you're still early to mid-career, make sure you're in a setting where that sort of work is valued. Because I've been lucky in most of my career to be in settings where that was actually an advantage, not a disadvantage. But I've also seen places that are strictly counting the number of R01s you can get by the time you go up from promotion to assistant professor to to assistant to associate professor. And if you don't have those 2 or 3 R01s on the shelf, you don't have a chance. That's going to discourage engaged work that's going to be a little trickier and take longer. So great question.
Yeah, those are wise comments, and I completely agree. Dr. Brownson, there are 2 questions about the thing. So let me see if I can kind of combine them together a little bit. So one of them by Lisa is, while you're presenting on this topic of evidence, which of your recommendations apply to evidence for implementation strategies, and which apply to evidence-based practices or programs, i.e. the things? And then the other question sort of, I think, is related, which is, do you think the use of the phrase "the thing" in implementation research actually minimizes important considerations with respect to evidence? And I think it's a great 2-part question.
Yeah, I think too much emphasis on the thing. So this is something I think Jeff Curran coined, the idea of the thing. So the thing is I'm going to paraphrase, I'll probably get it wrong, but the thing is the evidence-based intervention itself. Okay, so the practice we're trying to get, so the vaccination, we're trying to get more widespread use of vaccination. In some cases, it is some of the interventions that would increase vaccination. The strategies might be the changes within an organization that might lead toward the uptake of that vaccination, the how you get the thing done more commonly and more frequently. I think that evidence considerations apply to both. They apply both to the EBI, if you call that the thing, and the strategy itself. I think that there's a lot more literature on the EBI, the thing, than there is on the implementation strategies. but both are important. They also interact, and probably most of you are familiar with this idea of hybrid study designs. It's become a very hot topic in implementation science now for about a decade, that Jeff Curran, another really great contribution he made. And that's where I think you can kind of do both and sort of mold together the idea of what an evidence-based intervention means, and when you're studying effectiveness of the intervention at the same time you're studying the strategy itself. One thing I'll say about the strategies, there's some really great typologies of strategies now. There's a lot less on, you know, which of these strategies are going to be most effective in the situation where I'm trying to do implementation science. And that's tricky because context can be so different because you've got so many different layers to it. Did I get the second part of that too?
Well, I think the second part was, are we sort of minimizing the importance of all of this variation in evidence if we are trying to say what is the thing, like very specifically trying to define it, I think.
Yeah, that's a great comment. So one of the things, another word of the thing, but one way that we try to teach people when we're working with practitioners in evidence-based public health, and we're trying to help them choose intervention options, is we often say there are usually multiple rational choices about which EBI you're going to choose. And so putting too much emphasis on one thing is probably too narrow of a look at the evidence there. And getting people to think, we try to get people thinking about a menu of options. Here are all different sets of EBIs or strategies that have at least shown some evidence of effectiveness. If you're doing something that's really outside the box, that might make perfect sense for the context you're in, but you want to make sure you evaluate it well if you're working in a practice setting. So I think I would agree with the comment and the way it was phrased.
Okay. Oh, the questions are like just flying in. Another one here next is, are there high quality studies investigating thresholds among clinicians to use evidence in practice?
Yeah, that's a great question. There are some questions. I think there's broader studies I know of where people ask clinicians about their bar for evidence or their sources of evidence. So for example, do they go to a systematic review? Like, does a clinician regularly review journal articles or systematic reviews like Cochrane, or do they rely on team management of a condition, or do they rely on professional organizations? I think the best of all worlds with the thresholds are when people resonate back to a high quality threshold, but then they're getting input from a variety of different sources. So for example, public health practitioners, their number one or number two trusted source is always their professional associations, the groups that they resonate with. Like if you're in local public health, it's the National Association of City and County Health Officials. And so that's important because that's sort of the intermediary between the generation of evidence and the use of evidence. And there's probably a lot of parallel things with clinicians as well.
Sure. Here's another one. I think it was Einstein who said something like, you can't fix the problems with the same system that created them. Thinking about equity, I cannot help but wonder what we might learn by an equity first approach rather than an equity two approach. I think we might find a way to improve outcomes for everyone. Any thoughts about this, and are there implementation approaches that fit into such an idea?
Yeah, I totally agree. There are some examples, and it's sort of shifting the equation about how we typically do research. It's shifting the decision making, it's shifting the power. I know this is one example that might fit. It's more of a policy oriented one, but in Tacoma, Washington, and I don't know these individuals, I just read about this. They do this basically community-based budgeting for their local health department. So they work with the community on priorities, and they work with the community on, here's the funds we're going to spend in Tacoma, Washington. How do you think we should spend it? It's shifting the power, and these are working on health equity. So these are trying to focus on the populations most affected by disparities, and shifting the power equation so that the most affected individuals and populations have a direct say in the allocation of resources and the intervention. And so I think I like that framing of equity first. And I think that the way to sort of build that in is partly for researchers or practitioners or policymakers to give up some power and hand over the things that are usually controlled by the so-called experts, who are usually the people with a lot of degrees after their name, which may not be the experts at all if you really boil down to it. So
Yeah.
I totally agree with that.
Yeah, love it. Equity first, not just equity too. Couple questions about policymakers. Are there constructive ways to improve the gap between policymakers and researchers? How can we effectively bring policymakers and leaders on board despite the increasing evidence things are not really working, especially in low and middle income countries?
Yeah, great questions. There are approaches, and there's a whole field of policy implementation science. If that individual wants to email me separately, I'll be glad to send some readings for them. One of the most promising ways is, and I'm thinking here of state level policymakers, one of the most promising ways is thinking about audience segmentation in policy. So, for example, studies we worked on and a colleague, Jonathan Pearl, has worked on in the mental health space, is that there are distinct segments of policymakers who are driven by different norms and values. For example, in mental health laws, there's a group of people initially would be reticent to support mental health legislation, but if you frame it as a cost issue, that how much mental health is costing, don't frame it as a social good, but frame it as a cost. You can move those people along the continuum. So framing messages, targeting messages, and then using multimodal dissemination strategies. There's very little evidence in policy dissemination about single strategies that work, but there's decent evidence, at least, of multimodal strategies that affect policy. And also, I think affecting the policy intermediaries, we often underestimate the power of the staffers who work on policy, who are the ones often writing the legislation and writing the testimony and advising the official that's elected to office about what they should be working and voting on.
Yeah, well, it seems like we need to also better understand the context of policy making itself for our own. I mean, we may not understand how that works, and it's hard then to engage them. So I appreciate that. We'll take one last one here, which is really a really nice question. You mentioned that there is a positive bias. It probably begs the question, do we learn more from successes or from failures? But more importantly, what programs should be discontinued or adjusted? Any suggestions that you can make regarding selection of research? Any suggestions to make the selection of research more random to get a broader spread of success/failure?
Yeah, that's a great question. I would think of it as the pipeline for research. So we've got funded research on this idea of misimplementation. And I'll tell you, we got a lot of pushback from our practice partners when we first started doing it, because they were sort of like, you're going to tell the world we're doing things wrong and they're going to cut off all our funding. So it took us a long time to convince the practice world that this was a good thing to study and that we can make better use of the limited resources we have if we study this and we do a better job in addressing misimplementation, which in some ways is a failed program, but a program that could be changed in a different way so that it could be improved. And then I think it's incumbent on the funders to fund more of this, and then incumbent on us to do the research, and then also what we published and work on publishing things that are not as positive as we had, and so trying to avoid the publication bias that's so common.
Well, we're right at time, and there are still some more questions which we will send you by email. But thank you so much for a fantastic presentation. Thank you everyone who joined for all the questions. And each question could have been a discussion of 15-20 minutes in itself.
Yeah, there was some I was scanning the questions at the end there. There were a lot of good questions. We could have another discussion seminar, because I mean, many of you could answer these questions better than I.
This is fantastic. Thank you so much, everybody.
Thank you. Thanks, everyone.
We'll see you.
Okay.